The first story is about glargine, and that's a long-acting insulin, which you may not use very often. But there was a story from Germany a couple of years back that suggested that this long-acting form of insulin might be related to an increased incidence of cancer. Well, the answer appears in this news item, and the answer is no, it does not. Big study, 22,000 people on the drug, followed for considerable time, compared to 5,000 matched controls who were taking the conventional insulin. And there was no difference in incidence of any cancer at all. The second story is a sort of difficult piece of epidemiology in that it picks up a risk factor which you can't do anything about, namely for postmenopausal women, height. And this is, again, a very large study, a very good study, which has shown that for every 10 centimeters above the norm, women have a slight increase, 2 or 3% increase of getting a number of common cancers: cancer of the breast, cancer of the ovary, cancer of the colon, cancer of the rectum, melanoma, cancer of the thyroid. Not terribly clear why that should be, and also why it should not be picked up until postmenopausal age. That's the highest instance, of course, of all of these cancers. And a number of theories have been put forward by these epidemiologists to do with growth factors and spurts of growth hormone, which are associated with the increased growth. And the headlines on the newspapers were, tall women get much more cancer. My caveat is that it's not a huge increase in cancer, and what's a tall woman going to do about it anyway? Perhaps maybe be more cautious, more surveillant, make sure that you get your mammograms and your cervical smears done, etc. So those are two big population studies. An important announcement from the FDA is that Afatinib has been registered on the basis of a large randomized trial for non-small cell lung cancer patients who've got epidermal growth factor receptor 21 mutations or 19 mutations. This is an oral drug, and it's easier for patients to take inevitably. The dose is 40 milligrams per mouth daily, continued until disease progression. Patients, non-small cell lung cancer, are typically elderly. They've typically got comorbidity. They will have other smoking-related problems because, of course, most of them will have smoked in order to get their lung cancer. So an oral medication is to be welcomed. An interesting story is reported from Imperial College in London, where surgeons have hooked up an electro sensor to a mass spectrometer to the end of a knife. And they claim now, in studies of 91 patients who were operated on with this knife, that the knife picking up signals through the probe, sending the signals to the mass spectrometer. The mass spectrometer identifies a number of cancer-related signatures and tells the surgeon, yes, you're still cutting through cancer tissue, or no, you're into normal tissue. It's very, very early days, but the technique picked up 100% accurate estimates according to the check with histology. And it's a very clever use of technology which has been available for a long time, but which hasn't been put together and translated into the clinical situation. It needs to have much more testing. It needs to be costed clearly, but should it indeed work out to be advantageous, then it's obvious, at least to any surgeon doing cancer surgery, that the ability to see where the cancer tissue stops and the normal tissue begins with a better instrument than two eyes, or even two eyes and a telescope, would be a big advantage, because, of course, the major principle of cancer surgery is to take another centimetre of normal tissue surrounding the malignant tumour. I'd like to add my sadness to the whole panoply of European oncologists when we heard about the death of Professor Maurice Staquet. Staquet was a personal friend of mine. He was a very, very great man. He was a pioneer, together with Professor Henry Tagnon at the Institut Jules Bordet in Brussels. They put together not just the EORTC, the European Organization for Research and Treatment of Cancer, but the data center. And Staquet was its first director, and he took it from zero to the extraordinary position of being able to run something like 40 or 50 trials with 6,000 patients a year, all quality controlled, excellent audits, superb publications. Maurice Staquet retired 10, 15 years ago and was succeeded by François Meunier. And it's quite remarkable that the EORTC reached its 50th birthday with only 2 directors. Luckily, Maurice Staquet lived long enough to enjoy the 50th anniversary celebrations a few months ago. And we at eCancer salute him for his extraordinary endeavours to unite oncologists from all over Europe in the pursuit of evidence via clinical trials.